Hello everyone. Our topic for today is lower gastrointestinal bleeding. The following are the objectives. At the end of the lecture, we will be able to identify the areas that belong to the lower GI tract, to define what is lower gastrointestinal bleeding, to discuss the common etiologies that causes lower gastrointestinal bleeding, and to be able to diagnose and manage patients with lower gastrointestinal bleeding. Let us define first certain terminologies that is related to bleeding. Hematemesis is the vomiting of red blood or coffee ground material. Hematochezia is the passage of red or maroon blood from the rectum. Melena is the passage of blocked, tarry stools that is composed largely of blood that has been acted on by gastric juices. This is indicative of an upper GI bleeding. Obscure GI bleeding is when no source has been identified. When there is presence of hematemesis, melena, or hematochezia, this is termed as overt GI bleeding. When it occurs in the absence of overt bleeding and is identified only by lab test or stool exam, it is considered to be occult GI bleeding. Massive GI bleeding requires 3 to 6 units of transfused blood within 24 hours. The picture on your right is hematochezia. The one on your left is melena. Lower gastrointestinal bleeding is defined as an abnormal intraluminal blood loss from a source distal to the ligament of Treitz. The ligament of Treitz is the one that clinically demarcates the boundaries between the upper GI and the lower GI tract. Upper GI tract is composed of pharynx down to the upper border of the ligament of Treitz, whereas the lower GI tract is composed of the ligament of Treitz down to the rectum. Acute GI bleeding typically presents with overt blood loss that can be readily recognized by the patient. On the other hand, chronic GI bleeding is already present for a long period of time and it is usually occult, which may go unnoticed to the patient. The following are the common causes of lower GI bleeding: angiodysplasia, diverticular disease, carcinoma, polyps, ischemic colitis, Crohn's disease, ulcerative colitis, hemorrhoids, and anal fissure. The most consistent and apparently the earliest abnormality noted in all lesions of angiodysplasia was the presence of dilated, often huge submucosal veins. Some authors believe that the lesions were acquired, resulting from degenerative changes that accompany aging. Hemorrhage from colonic diverticulum is the most common cause of hematochezia in patients greater than 60 years old. It is most commonly seen in the right colon and cecum. The localization of diverticular bleeds should include colonoscopy, which is diagnostic and at the same time therapeutic. There are two types of inflammatory bowel disease, but let us discuss first ulcerative colitis, which is a mucosal disease that usually involves the rectum and extends proximally to involve all or part of the colon. It is limited to the mucosa and superficial submucosa. Patient presents diarrhea, rectal bleeding, tenesmus, passage of mucus, and crampy abdominal pain. Crohn's disease is characterized by focal inflammation and formation of fistula tracts, which resolves by fibrosis and stricturing of the bowel. It is a transmural process that can affect any part of the GI tract and forms non-cacheating granuloma. In 90% of the cases, the terminal ileum is involved. Initial presentation of patient usually mimics that of acute appendicitis, wherein there is pronounced right lower quadrant pain, palpable mass, fever, and leukocytosis. Pain is usually colicky. It precedes and is relieved by defecation. This table summarizes the differences between ulcerative colitis and Crohn's disease. The one that presents with blood in stool is ulcerative colitis, whereas pain, abdominal mass, and colonic obstruction is evident with Crohn's disease. The one that does not respond to antibiotics and does not recur after surgery is ulcerative colitis. Cobblestoning and granuloma on biopsy is present with Crohn's disease. Upon radiographic examination, small intestine and terminal ileum is affected in Crohn's disease. It also produces colitis and stricture. The typical low-fiber, high-fat Western diet is associated with constipation and straining, leading to the development of symptomatic hemorrhoids. Hemorrhoids is the most common cause of lower gastrointestinal bleeding. There are two types of hemorrhoids, the internal and external. Among these two, internal hemorrhoids represent the majority of hemorrhoids. Patient usually presents with painless rectal bleeding with bowel movement and protruding rectal mass. The diagnosis of hemorrhoidal disease is made on physical examination. Inspection of the perianal region for evidence of thrombosis or excoriation is performed, followed by a careful digital rectal examination. The most common cause of rectal bleeding in infancy is anal fissure, but it is more common in 30 to 50 years old. Trauma to the anal canal is usually located at the posterior area. Patient usually complains of sharp, knife-like pain and bright red rectal bleeding with bowel movements. Colon and rectal cancer can also be a cause of lower gastrointestinal bleeding. However, they are more common among greater than 60 years old. Polyps of colon and rectum rarely causes massive bleeding, but they have a malignant potential. Ischemic colitis may be acute, transient, or progressive. They usually present with bleeding per rectum, diarrhea, and abdominal pain. How do we diagnose patients with lower gastrointestinal bleeding? To fully evaluate patients with lower gastrointestinal bleeding, we have to extract the following data in their history. Ask the patient to characterize the bleeding. Is it hematemesis, hematochezia, melena, or occult? In lower gastrointestinal bleeding, patient usually presents with hematochezia, but it can also present as melena if the source is within the small intestine or the ascending colon. Check how long the bleeding is occurring. Is it episodic or continuous? Ask the patient if there is any associated symptoms such as abdominal pain or distension, constipation, changes in appetite, weight gain or weight loss, diarrhea, fever, etc. It is also important to know whether the patient has a history of hematologic, gastrointestinal, or oncologic diseases. Note whether the patient is under medications, particularly antiplatelet drugs, anticoagulants, NSAIDs, or any herbal medicines. Ask also whether the patient is alcoholic, smoker, or had previously taken prohibited drugs. Assess the vital signs of the patient. Focused PE involves abdominal and rectal exam. Diagnostic tests that are usually requested are CBC, blood typing, liver function test, and PT-APTT. If the patient is hemodynamically stable, less than 40 years old, with minimal bleeding, we can do flexible sigmoidoscopy. But if the patient is hemodynamically stable, less than 40 years old, with more copious bleeding, family history of colon cancer, and iron deficiency, we can do colonoscopy. If the patient is hemodynamically stable but greater than or equal to 40 years old, we can do colonoscopy. Once the site is identified and the bleeding stops, we can now manage our patient accordingly. But if the site is identified, however the bleeding persists, we can do angiography. But if the bleeding still persists, we can opt to do surgery. If the site is not identified, we have to work up for small intestinal or obscure bleeding site. If the patient is presenting hematochezia and hemodynamic instability, we have to do upper endoscopy to rule out an upper GI source before evaluating the lower gastrointestinal tract. Once you identified that there is no upper GI source and the patient is able to prep, we can do colonoscopy. But if the patient is too unstable to prep, we have to do angiography. If bleeding still persists together with instability, we have to do surgery. Flexible sigmoidoscopy, colonoscopy, and CT angiography are just some of the diagnostic procedures that we can request for us to be able to locate the site of bleeding. Fecal occult blood test is done when the blood present in stool is not grossly visible. This test is recommended for colorectal cancer screening, beginning at the age of 50 for average risk patients. Positive results necessitates colonoscopy. How do we manage patient presenting with lower gastrointestinal bleeding? First step is initial resuscitation. When patient is unconscious, obtunded, having inadequate gag reflexes, or have signs of decreased sensorium, check the airways of the patient if there is a need for intubation. This is to protect the patient from aspiration. Most commonly, volume resuscitation begins with crystalloids, particularly NSS, since it is the only solution that may be administered with blood products. Patient requiring further resuscitation should receive transfusion with packed red blood cell until intravascular volume is restored. Transfusion is recommended when the hemoglobin drops below 7 grams per dl. Platelet count should be monitored closely since platelet transfusion may be infused if patient's platelet count goes down to 50,000 platelet per microliter, which is considered to be a significant thrombocytopenia. We need also to discontinue the patient's use of any offending anticoagulants or antiplatelet drug. Patients with uncontrolled chronic and massive bleeding may proceed to hypovolemic or hemorrhagic shock. There are four classes of shock: Class 1, 2, 3, and 4. A healthy person can endure a loss of 10 to 15% of total blood volume without serious medical difficulties. The pulse rate starts to increase in Class 2. Class 1 and 2 usually respond well to crystalloids. On the other hand, BP starts to decrease in Class 3. It is in this class that we usually initiate transfusion. These are the blood products that are usually transfused to patients with lower gastrointestinal bleeding. It is important to note their specific actions. 1 unit of packed red blood cell can increase hemoglobin by 1 gram per dl and can also increase hematocrit by 3%. Fresh frozen plasma are usually given to patients with coagulation problems, liver disease, or disseminated intravascular coagulations, since it contains clotting factors. The main indications for use of platelets are bleeding, DIC, and severe thrombocytopenia. Platelet concentrate is stored at room temperature and should be with constant agitation. Once initial resuscitation is done, we can now manage our patient appropriately. Treatment of colonic diverticulum involves mesenteric angiography with coiling and segmental colectomy. Hemospray can be applied during colonoscopy. It is a powder that basically forms a barrier over the vessel wall to stop the bleeding. Eventually, the colorectal cancer itself is treated with the surgical resection of the tumor or chemotherapy. Treatment of hemorrhoids consists of dietary and lifestyle modifications such as drinking more water and having a diet rich in fiber because it will help in softening the stool. Analgesic creams along with hydrocortisone suppositories and sitz bath can relieve pain. Sitz bath is a warm shallow bath that cleanses the perineum and relieves irritation and pruritus. With internal hemorrhoids that persistently bleed, rubber band ligation can be done using an anoscope to view the hemorrhoid and then tie it off at its base. For external hemorrhoids, a hemorrhoidectomy can be done, which is the surgical removal of hemorrhoids. Anal fissure can be relieved with sitz bath, high-fiber diet, stool softeners, and topical anesthetics. Surgical procedures such as anal dilatation and lateral internal sphincterotomy can be done. But before we end, let us summarize the things that we've discussed. When confronted with a patient with lower gastrointestinal bleed, there are three things that are critical. First, assess hemodynamic status. Second, ensure hemodynamic stability through volume resuscitation. Third, determine the cause of bleed. The initial focus must involve the assessment of hemodynamic status. Is the patient hypotensive or tachycardic? If yes is answered to either of these questions, transfer the patient immediately to the emergency room for assessment and stabilization. The next initial step must focus on volume resuscitation. Insert two large bore IVs and provide a fluid bolus. Get blood work and remember to type and screen as they may need transfusion. In addition, assess coagulation status, as coagulopathy may need to be reversed. Once stable, establish the cause of the bleed. An upper GI source with rapid transit must be considered, and an upper endoscopy is indicated to rule out an upper GI source in the face of hemodynamic instability. Up to half of the cases of lower GI bleeding is caused by diverticulosis. Diverticulosis is usually painless. Causes of lower GI bleeding may be associated with pain and cramping, such as ischemic colitis, infectious colitis, and inflammatory bowel disease. Hemorrhoidal bleeding is also frequent. It is associated with hard stool and constipation. Patients often complain of blood on the toilet paper after wiping. Always consider the possibility of colorectal cancer, especially in elderly patients or those with positive family history. Rare causes include radiation colitis and NSAID colitis. Colonoscopy is often the necessary diagnostic test to confirm the etiology of the lower GI disease, and management strategies should focus in addressing the etiology of that disease. This is the end of my lecture. I hope you have learned something. Thank you very much.